GTN 0.5 mg tablets are indicated for prevention and treatment of stable angina. GTN tablets are to be used sublingually (SL), which means the tablets are to be placed under the tongue to dissolve. At the first sign of attack, one tablet can be placed sublingually, and this one tablet can be repeated every 5 minutes if needed, for a total maximum of 3 tablets within 15 minutes. If there is no relief after 3 tablets, patients should seek medical attention promptly. GTN should be avoided to be combined to be given with other nitrates such as isosorbide dinitrate, isodil, isosorbide mononitrate, IMDAX, or nitrogen patch, as well as GTN injections. Administration of GTN together with phosphodiesterase 5 inhibitors should also be contraindicated. GTN is contraindicated in patients with raised ICP, patients with hypotension, hypertrophic obstructive cardiomyopathy, cardiac tamponade, aortic or mitral stenosis, or cor pulmonale. GTN injection is indicated for patients with heart failure associated with acute myocardial infarction, unstable angina, as well as acute pulmonary edema. The dose in adults is an infusion of 5 mg per minute to be titrated in 5 mg per minute increments at intervals of 3 to 5 minutes, guided by patient response, which means from 5 mg per minute you can increase it to 10 mg per minute and then to 15 mg per minute. If no response is achieved at 20 mg per minute, then you may increase it by 10 to 20 mg per minute, which means from 20 mg per minute you can increase it straight to 30 mg per minute and then to 40 mg per minute. In peds, the dose is usually between 0.5 to 5 microgram. Avoid usage of GTN injections with other nitrates as well as the PDE5 inhibitors. GTN injection is contraindicated for patients with raised ICP, hypotension, hypertrophic obstructive cardiomyopathy, cardiac tamponade, aortic or mitral stenosis, or cor pulmonale. Diuretics available as floor stock in CCU and emergency departments is furosemide injection, indicated for edema associated with heart failure, hepatic cirrhosis, renal impairment, and nephrotic syndrome. The dose for adults is an initial dose of 20 mg to 40 mg. It may be repeated after 2 hours. It can be increased by 20 mg until a desired response is achieved. It may be given as a once daily dose or twice daily dose. Doses higher than 50 mg should be given by infusion of 10 to 40 mg per hour. It can be doubled when necessary to a maximum of 80 to 160 mg per hour, maximum of 1.5 gram per day. Pediatric bolus dose of furosemide is 1 mg per kg. It can be given 6 hourly. Infusion can be given between 0.1 to 1 mg per kg per hour. Furosemide is contraindicated in patients with severe sodium depletion and severe fluid depletion. It is also contraindicated in patients with mannitol is the last medication covered for this session. Mannitol is indicated for raised ICP or acute renal failure oliguria. The dose for raised ICP is 0.25 to 2 gram per kg over 30 to 60 minutes. For acute renal failure oliguria, The treatment dose is 50 to 100 gram IV. Mannitol is contraindicated for patients with heart failure or pulmonary congestion progressive after mannitol initiation. Mannitol is also contraindicated for patients with anuria due to severe renal disease or patients with renal damage or dysfunction after mannitol initiation. As a summary, we have covered these medications: antiarrhythmic, CCB, inotropes, vasodilators, beta blocker, nitrates, and diuretics. Remember that medication appropriateness review includes checking if the drug dose, frequency, route are appropriate, to check for polypharmacy, check for allergy or contraindications, check for potential interactions, and to check the weight-based dose or potential organ toxicity. Remember the new highlights in the JCI latest 6th edition. At least 4 of these elements must be reviewed: allergies, lethal interactions or life-threatening interactions, weight-based dose, and potential organ toxicity. Thank you for your kind attention.